Appreciate you all joining. My name is Rob Latika. I'm a project manager with Admedicum, and we are at the first webinar of the year 2024 with the Alliance for Pulmonary Hypertension. We're supporting the Alliance as the Secretariat, and the Alliance is a nonprofit organization registered in Brussels, whose mission is the sharing of knowledge and expertise in PH. We've been working for the last 3 years with the Alliance, and today our esteemed speakers will address the very important topics of lung and heart-lung transplantation in pulmonary hypertension. In particular, the indications, the surgical techniques, post-transplant challenges, and of course, Florence is here to share the patient experience throughout. You can write questions in the chat box, and at the end, after all the speakers have talked, we'll go through some of those together. In the next few weeks, the recording will be made available on the knowledge sharing platform, along with probably most of the slides. Our next webinar is going to be on April 29th, so keep your eyes open for that. It'll be about surgical interventions in CTEPH with 2 leading world experts in the field, Professors David Jenkins and Hiromi Matsubara. So without any further ado, I think, Laurent, are you ready to go first?
Yes, I'm ready.
Great. Yeah, please introduce yourself, and also my colleague Andreas is here.
Okay, thank you very much for this introduction. So it's a very great pleasure to be involved in this webinar today. To introduce myself briefly, I am pulmonologist in the French Reference Centers for Pulmonary Hypertension, and I am in charge of the intensive care unit in our centers, and I am also in charge to prepare patients for the project of lung transplantations. So I will discuss in the first step the screening and the process to go to lung transplantations. First, it's very important to remember that the development of the medical therapies for pulmonary hypertension considerably improve the prognosis, the symptoms, the quality of life of pulmonary hypertension, but it remains an irreversible disease. So consequently, lung transplantations remains an important treatment option for patients with pulmonary arterial hypertension who are refractory to optimized medical therapy. And to go further, a project of transplantation should be considered at an early stage in the patient's care, because it remains an ambitious, it remains a challenging project, which can only be planned if all the conditions are met. And that's what we are going to discuss now. So briefly, we have few data about the epidemiology of lung transplantation in registry. Just I reported here a recent analysis of the French reference centers, and you can see that over the last 10 years period, 5% of patients with PH were transplanted, received lung or heart-lung transplantations. So the next. And if we analyze the transplant registry, you can see that pulmonary arterial hypertension never represents more than 8% of all the indications for lung transplantations. The next. So the access to transplantations remains challenging for different reasons, but it is a project that should be a source of hope for the patients with severe PH and who are potential candidates for such projects. So it's challenging for different reasons. The first reason, as I said previously, patients with PH are representing a small proportion of transplanted patients, and lung transplantation in PH requires highly specific intra and post-operative strategies, and these points will be detailed by the next presentations. The second point is that the prognostic parameters for the risk assessment on NIST and post-operatively in PH are very different for the other indications for lung transplantation, and that can lead to inequities in the organ allocation process. The third point is that severe form of PH, in this form, there is a risk for developing acute episode of decompensation that could need priority access to transplantations. And the last point is that for selected patients, ERN-Lung transplantations can be required and can complicate the access to transplantations. But that it's very important to underline is that now there are now solutions that can be proposed and advances that have been made or are being developed to optimize access to transplantations for patients with pulmonary arterial hypertension. The next slide. So one key point is that the transplant project should be considered at an early stage in the patient's care and should be carried out in several stages. The first stage is the time for discussion about transplant as concept and potential therapy. The second step corresponds to the lung transplant assessment to determine eligibility and timing of listing. And the last step is listing for lung transplantation that should include prioritization for transplantation and bridging options. So it's important for the medical team to determine the best timing for each of these steps according to the evolution of the disease and according to the specific context for each patient. The next. So as you know, the treatment algorithm for pulmonary arterial hypertension is essentially mainly on risk stratification during follow-up using a multi-parametric approach. And the aim of this risk stratification is not only to set therapeutic goals, but also to detect patients who are not responders of treatment to consider transplantations when treatment is at its maximal level. The next. But what is important, the next slide, please. What is important to underline is that this risk stratification tool should not be used in isolations to inform when to refer a patient for transplantations. Pulmonary hypertension is a group of conditions whose prognosis may be influenced by many parameters that should be included in the decisions. These parameters can be specific to pulmonary hypertension, like associated conditions and comorbidities, the quality of life, the specific indications for ERN-Lung transplantations that will complicate access to transplantations. And the outcome can be also influenced by specific complications like hemoptysis of coronary compression, for examples. And in addition, it's very important to assess the best timing for transplantations. It's very important also to take into account the parameters that can influence the waiting time on list, like the morphometry, the blood group, the anti-HLA sensitizations, and of course the parameters that are related to the centers, the healthcare system in each country. So the next step, please. So taking in all these parameters into account, the first question is, when should we talk about transplantation as a concept and potential therapy? The next step, so for this point, there is no clear consensus on when transplantations could be introduced as a concept with the patients. This depends on the severity of the underlying disease and the patient's expectations. In my opinion, I think that it is reasonable to say that the notion of transplantation should be introduced to patients as soon as the diagnosis is made when the status is severe and requires maximum treatment as first-line therapy. When the risk status at baseline is low or intermediate, notion of transplantations as a potential treatment option could be introduced in a second step after a failure of a first-line therapy. But this must be adjusted on a case-by-case basis. So why it is important to introduce early to the patient the concept of lung transplantations for different reasons. First, it's allowed the patients to prepare for this therapeutic eventuality. The second point is that it provides time to help the patients address modifiable factors that may initially preclude eligibility, such as financial resource, elevated BMI, vaccinations, deconditioning condition, and social support or substance misuse disorders that can be difficulties for the lung transplantations. So the next. So the second time is the lung transplantation assessment to determine eligibility for such projects. So once again, the decisions to refer for transplant assessment should be based on different parameters. The next step. It can be carried out at the time of diagnosis if there is a variant of the disease that responds poorly to treatment. It is the case, for example, for the pulmonary veno-occlusive disease or such conditions that PH due to scleroderma with venular involvement or associated extensive pulmonary fibrosis, or severe form of pulmonary associated with lung disease, for examples. And during follow-up, we have to consider assessment for lung transplantations if you have to increase the treatment due to intermediate high risk or high risk status after first-line therapies that require the use of prostaglandin analogs, for example, or patients who doesn't reach low risk status after a first-line triple therapy, including parenteral prostacyclin. We can also consider that it is time to refer for an assessment for such project if there is a significant right ventricular dysfunctions despite an optimal medical therapy. And we have also other specific conditions that could be the time for assess for transplantations, episode of acute decompensated PH that requires hospitalizations, onset of new atrial arrhythmia, for example, or recurrent of non-severe hemoptysis. So the next slide, please. So the time to screening procedure has different objectives. The first objective is to meet the transplant team in charge of the lung transplant process, including surgeons, medical doctors, anesthesists, psychologists, transplant coordinator, and social worker. The second objective, the next slide, is to screen absolute or relative contraindication for lung transplantations that are not specific to pulmonary arterial hypertension. I listed some of them in the right of the slide. These contraindications are related to of course, the acceptance of transplant program by the patients, severe organ failure, infections, cognitive impairment, or malignancy. The next slide. The next step is to determine the type of transplantations. So the bilateral lung transplantation is the preferred option for the vast majority of cases. Lung transplantations can be only considered in very specific cases. For example, non-correctable cardiac conditions, coexisting left side heart disease, and in some cases of pulmonary artery aneurysm or massive cardiomegaly. And only in a very few patients, in some patients, single lung transplantations may be sufficient, but only if there is a very mild pulmonary hypertension associated with a lung disease. The next step. So with all this information, the medical team determine eligibility and timing for transplant, but the final decision, of course, should be jointly made between the patients and the medical team after informing of the risk and the benefits of the lung transplantations. The next step. So once the project has been validated, it's not necessarily the right time for listing, but all has been anticipated if there is a progression of the disease in the future. And the decisions to listing will depend on the risk and the therapeutic pressure. The next slide. So I listed here some conditions that could list patients for lung transplantations if he is a candidate for lung transplantations. During the follow-up, according to the risk status, of course, we have to list if the patient is at high-risk category despite an optimal medical therapy. If there is an intermediate high risk with significant right ventricular dysfunctions, recurrent hospitalization for right ventricular failure despite optimal medical therapy, and if there is failure of other organs due to the right ventricular deficiency. And there is also specific indications like worsening in hypoxemia or hemodynamics in PVOD, for example, diagnosis of underlying interstitial lung disease, COPD, with very severe respiratory insufficiency. And of course, all these indications indicate that it's time for listing after determining if the patient is a good candidate for such projects. The next slide, please. So the next, of course, you have to modulate all these parameters according to the healthcare system and the graft allocation rules that can be very different from one country to another country. You have here the example of the Europe, and you can see that there is different rules for the graft allocation. Some country can use the lung allocation score, and other country don't use the lung allocation score. And we can see that in some countries there is some emergent program on lung transplantations, and in this country it can be difficult to have access to lung transplantation for patients with pulmonary arterial hypertension. So the next step. So just a word about the pulmonary hypertension in the lung allocation score that is used in some countries in Europe, but also in US. And you can see that it was the pH, there was an inequities in the access to lung transplantations with the initial lung allocation score. You can see here the results 10 years after the implementation of the lung allocation score in US, and the proportion of patients who were transplanted with pH was very lower in comparison with the other indications for lung transplantations. But this was changed, the next slide. And it was introduced in the second step, specific parameters for pulmonary arterial hypertension, and the weight given to the pH was higher, and finally it improved the condition and the access to lung transplantations for patients with pulmonary hypertension. So the next, nevertheless, despite the significant improvement, we can see that pulmonary hypertension remains one of the etiologies for which access to the transplantations remains the most challenging with the lung allocation score. The next step. So since last year, the lung composite allocation score was implemented with several changes that could be interesting for pulmonary hypertension, but this should be properly evaluated in the future. And now the lung allocation score represents 50% of the overall score, and 50% depends on the recipient candidate's biology. That could be very interesting for patients with pulmonary arterial hypertension. The next steps. So another major advance has been the introductions of systems allowing urgent access to transplantations for PH patients in the vast majority of the lung transplant programs. Indeed, you can see that when you have a severe pulmonary hypertension, you can develop acute decompensated of pulmonary arterial hypertension, and many progresses have been made to improve the prognosis of these very specific situations with the development of the use of extracorporeal life support in these cases, but also with the development of urgent program with priority access for patients who are admitted for these life-threatening conditions in intensive care units. The next slide. And that's why it's very important when the young patients who are potential candidates for lung transplantations or who are listed for lung transplantations, who develop acute decompensated pulmonary hypertension, it's very important to manage these patients in the environment that is able to propose all the possibility, the use of the extracorporeal life support, but also the access to urgent transplantation in these very specific conditions. The next slide. And you can see that in France, when we implemented the high priority allocation program for these very specific cases of life-threatening conditions, you can see that we dramatically improve the access to lung transplantations for patients with pulmonary arterial hypertension. Before this program, only 50% of patients access to lung transplantations after listing. After the implementation of this program, more than 80% of patients who are listed access to lung transplantations now. So in conclusion, Access to transplantation for PH remains challenging, with a wide variability depending on the healthcare system and the graft allocation rules, but I demonstrated that many progresses have been made to improve the access to lung transplantations. The evaluation of lung transplantation should be considered at an early stage in the treatment algorithms. Patients be engaged in discussions about transplantation as a treatment option early in their treatment course. The final decision should be always jointly made between the patient and the medical team. Decisions to refer and then list patients should be comprehensive and include risk assessments, comorbidities, anticipated waitlist times, and donor pool. And of course, the development of urgent transplant program were a key point in the access for lung transplantation in patients with pulmonary arterial hypertension. Thank you very much.
Yeah, thank you very much, Professor Saval. This is Andreas Reimann. Sorry for joining late. I'm at a conference and I had some technical issues getting in. Thanks so much for sharing with us how you prioritize patients. And of course, we do have with Florence a patient who underwent all that. And Florence, I wonder if you have any comments at that moment. I think you're on mute.
Is that okay?
Yeah, now it's very good.
I was saying I have a story. I have my own story of the before the transplant. If you have any question about that, I can answer. But how do you feel?
Yeah, probably. Then we move first to Professor Hotzenegger, and then you can. It would be very helpful if you could share your own story and your own experience.
Yeah.
And
okay.
with that, I welcome Professor Konrad Hotzenegger from the University of Vienna. You are heading up the transplantation program there, and yeah, so this is yours.
Well, thank you very much, Andreas, for the nice introduction. I work at the Medical University of Vienna, and I'm the surgical head of the Vienna lung transplant program. I don't see my slides yet in presentation mode, Robert. Okay, so here are my disclosures. I work as a consultant for Medtronic, promoting the dual lumen cannulas, which are not at all usable in PH patients, and all patients gave their permission to show photographs. Next one. So I structured my talk by dividing it in three minor sections. First, I'd like to talk about indications and timing for lung transplantation. We've heard some of the parts of these parts. Then second, I'd like to talk about the choice of procedure. Then I'd like to finish by giving you an outlook of the postoperative management and the struggles we have in the ICU with the so-called cardiac remodeling phase. Next. So this is the Vienna lung transplant program. We're consistently performing between 100 and 120 lung transplantations a year. This makes us one of the largest transplant centers in Europe. And we are also a referring center for the treatment of pulmonary arterial hypertension. And therefore, PH account for approximately 8 to 9% of our transplantations. Next. Which is unique in a way if you look at ISHLT data, which is a big registry from the International Society of Heart and Lung Transplantation. You can see that only 2.8% of all recorded lung transplantations are performed for PH patients. And this results in a relatively low overall number. Therefore, evidence we have currently still, or most of the evidence is still limited to single center retrospective analysis. Next. So when is the right time, or what are the indications for lung transplantation in general? So in general, we can transplant any chronic or acute end-stage lung disease, which has failed all other medical therapeutic options. So for most patients, or for all patients, it should be the ultimate treatment. We don't want to see patients too early, but especially in PH, we don't want to see patients too late. It's important to remind everyone that we are trading one medical challenge for another. So a patient after transplantation remains a patient, but most of the time, the person after transplant has an excellent quality of life. Next. Yeah. So yeah, you've heard from Laurent a couple things about guidelines and when to step in. I think to sum everything up, whenever there is an inadequate clinical response to the primary therapy in high-risk patients, we need to see them at a transplant center to decide whether the person is a transplant candidate. And when you see the changes between the 2009 to the 2019 guidelines, you see that lung transplantation has steadily moved up in the algorithm how to treat PH patients, and nowadays it's more or less located in the center, which highlights the role lung transplantation nowadays has in the treatment algorithm of PH. Next. Yeah. So here you can see the problems arising when we get a referral too late. And these are real life pictures. These are two patients on the left-hand side with a right heart failure. So a very end-stage type of PH. All of these three patients got their transplant. However, I think it's easy to understand that we struggle a lot with transplanting the left-sided patients, and we would really like to see a patient, as you can see on the right-hand side. Next. So we have decided to transplant the patient. Now for the surgeon and for the patient, which type of procedure can we do? Next. Traditionally, PH was considered a classic indication for a heart-lung transplantation because the heart was considered too damaged to last after lung transplantation. Therefore, the pioneers of transplantation for PH decided to go ahead with a heart-lung transplant. And of course, Norman Shumway and Bruce Wrights, the two Stanford surgeons, promoted this. Next. And then in the 1990s and 2000s, transplant centers started to experiment with a double lung transplant approach, as they have done for fibrosis and COPD patients before, and explored the option for a bilateral lung transplantation only and spare the heart in the patient. And the reason why you can do this is because if you just exchange the lungs, the heart usually copes and undergoes a remodeling phase during the perioperative days and weeks. And with the right expertise in post-op care, we now know that PH patients can receive a lung transplantation only instead of a heart-lung transplant. Next. And these are the corresponding survival curves. As you can see, evidence is quite old. So these are 15 years old publications. But you see the patients after double lung transplant do similarly well compared to patients after heart lung transplant. Nowadays, the survival curves for double lung transplants only have significantly increased again. So nowadays, a double lung transplant has become the standard of care for PH. Next. So what about single lung transplantation? You might know that you can easily do a single lung transplantation in COPD patients or in fibrosis patients. In PH, this is not a recommended procedure, due to the fact that if you only exchange one side, you will have a significant overflow of blood through the single lung graft, which results in hemodynamic instability and a high rate of primary graft dysfunction. And then down the road, these lungs tend to fail early, and we have seen cases with an early chronic lung allograft dysfunction syndrome. So single lung transplant is not recommended for a PH. Next. So what is this cardiac remodeling? This really describes the phase a patient undergoes after a double lung transplantation and the recovery he or she has during her ICU stay. Next. And there are three important parts of the cardiac remodeling. We are always concerned about the right ventricle post-transplant. We're even more concerned how the left ventricle copes with the new circumstances. And of course, we are always considerate about the graft itself. Next. And I don't want to go too much into detail here, how you can balance right ventricle, left ventricle, and graft. But I just want to highlight that the use of postoperative prolonged veno-arterial ECMO has really been a game changer in treating PH patients post-transplant. VA ECMO is a kind of a slimmed down cardiopulmonary bypass machine which drains blood from the venous system and returns it to the arterial system, therefore bypasses blood from the pulmonary circulation and helps a pre-damaged PH heart to recover. Next. And this is a typical picture of a prophylactic post-operative ECMO in a PH patients. We need an additional like 2 or 3 centimeter incision above the femoral vessels, and then 2 cannulas are placed into the artery and the vein, and a third cannula is used to perfuse the leg. Usually such a post-operative veno-arterial ECMO in PH patients stays in for 2 to 3 weeks, and it kind of stabilizes the heart function of a patient. Then the cannulas can be removed and the patient usually recover in a much smoother way after the transplantation. Next. And here again, survival curves. This is an important publication published by one of my colleagues. And you can see that with a postoperative prolonged ECMO strategy, the Kaplan-Meier survival significantly improved. Next. And we now reach 1-year survival rates of 90%, which is excellent for PH. Next. And our data has been, so we are not on our own with this experience. If you look at other transplant centers that promote postoperative prolonged ECMO in PH patients, you can see that the early post-transplant mortality has significantly increased due to this strategy, and we can now offer 5-year survival rates of 75% to PH patients, which is really excellent. Next. But as we all know, survival is not a good outcome measure by itself. It's also important to look at the quality of life that comes with the improved survival. If you see on the left-hand side, activities are plotted in red that could not be done before the transplant despite optimal medical treatment in PH patients. And then you look on the right-hand side, and now the red so the red is there's hardly any red left, but most activities can be presumed by lung transplant recipients. Next. Yeah, and sometimes the overall organ function is so good that patients can actually climb on high mountains. Working in Austria, of course, I'm a proud mountain climber. This has been a project led by our lead pulmonologist, Peter Jaksch, who led lung transplant recipients, including PH patients, to the peak of Mount Kilimanjaro back in 2017. Next. Yeah, and this was the famous peak picture, and I'm excited to announce that actually next year we plan to conquer the Aconcagua, which is about 7,000 meters high, and I'm pretty sure that the transplanted patients will be successful there as well. Next. So in summary, lung transplantation for PH provides excellent outcome in experienced centers. We now face 1-year survival rates of above 90%, 5-year survival rates of 75%, creeping towards 80%. Early selection is important, so you should refer to a lung transplant centers immediately after failure of the initial treatment to decide who is a candidate and to offer the optimal treatment to PH patients. Thank you very much.
Yeah, thank you very much, Professor Hürzenegger, for this impressive presentation, impressive results. We are very happy that with Florence Perrin-Chabot, we do have a transplant patient, PAH plant transplant with us. And of course, my question to you is, what was your experience, and did you also experience a traumatic change in your quality of life in the course of your disease?
I did indeed. So, hello all. My name is Florence Perrin-Chabot. I was nearly 40, married, mother of 3, and I used to work as a financing pre-sales manager in a big computer company in Paris. That was before. Breathlessness was the main symptom. It appeared 1 month after the birth of my 3rd kid in August 2005. 2 months later, the cardiologist of the maternity hospital put the diagnosis in only 2 days for a probable PHA, which was confirmed by Professor Simoneau at the Hôpital Béclair in France. After 5 years with the tritherapy, sildenafil, Tracleer, and eventually prostacyclin, results from my workup have deteriorated. I was put on the transplantation list in September 2010, passed the pre-test, which already revealed that I had a very high amount of antibodies. In January 2011, I went for a usual pH check in Béclair. I had caught a cold a few days ago. I was in a pretty bad shape, red face due to high level of prostacyclin, like Conrad showed, swollen belly and feverish. And Professor Simoneau and Professor Dartevel decided to put me on the super urgency list. 16 plasmapheresis were tried on me during this month of January in order to remove or even just decrease those antibodies that would prevent any further transplantation, obviously. None worked, not even a bit. During that month of January, I had many calls from my family and friends. I was repeating my health report several times per day on the phone or to my visitors. So I decided to write what I called my Chronicles of Béclair, where I portrayed my patient day at the hospital, but also profiled some typical members of the medical or care team. After a few days, I was texting my chronicles to 50 recipients, and when they called back, our discussions were much more interesting. That helped me pass the time. And the doctors were starting to despair. I was told that if they would not find a solution, soon I would have to get back home. One professor, though, told me not to lose hope. He believed in me. I had not traveled that far to just stop here. And his name was Marc Imbert. And eventually February had just started and the transplantation team came back from an international congress where they received from Canadian pulmonologists the information that sometimes plasmapheresis was useless and transplantation should be operated with plasmapheresis during the operation, with ECMO and other incredible things that like that. That's all I could tell about it, actually. Now, what I clearly remember is that they explained this unexpected overseas solution at 11 o'clock in the morning on February 8th, that they would send me back in super urgency list for a fortnight while we would wait for some rescue lungs. At 5 o'clock in the afternoon, they came back in my room and said they had a graft for me. And so was I transplanted during the night of February 8 to 9, 2011 by Professor Elie Fadel in Hôpital ERN-Lung. Some 10 days afterward, I woke up. I had the fear of my life, thinking that the operation failed because I had so many tubes over my nose and mouth. I thought I would not breathe alone anymore. But that was just the beginning of my personal fight to get my life back. My body was my challenge. It did not hurt at all, no pain. The scar was really well done, a neat line across the chest, just below the breasts. But first I had to eat by myself and put weight on so that they would remove the feeding tubes and infusion. I went down from 2 to 45 kilograms and I'm 1.68 meters tall. I had to recover the use of my left arm. I was trapped right on the table during the whole operation because I was told that when I was unconscious, I had tried to remove all the tubes on my face with my hands and then with my leg. I had to walk again by myself. My first steps were helped with a walker, like an old lady. I had lost a lot of muscle mass. I wanted to understand all the drugs, the dosages that I was given in order to recover some sense of control. And I had so many pills at the beginning, each day, at breakfast, lunch, dinner. I had the feeling that my meals were pills. And I had to have the best respiratory functional scan results so that I would avoid the lungs cleaning process with the fibroscopy, which was so dreadful. And I also had to feel good for my worried but lovely family, husband, kids, sisters, and caring friends all around me. After a 3-week recovery period, I thought I was ready. So they let me have a weekend at home. But I was very fragile outside the hospital. I couldn't manage anything as I used to do before. I felt useless and weak. When I returned to ERN-Lung, I explained the situation, and they sent me on a rehabilitation clinic for 3 weeks. Then I was strong enough to get back home and start on my own. Every 2 weeks, then every month, progressively every 3 months, I had to do a medical checkup of my transplant. I was rapidly recovering, actually. I felt very lucky. My family was very caring and loving. I thought I should not have them disappointed. Some incidents, though, in my rather good health course. Yes, a small transplant rejection exactly 6 months after stopping the cortisone. Since then, I take 2 milligrams per day without discussing. I caught an aspergillus after some renovation work in my bathroom. I had 3 fibroscopies, which are a total nightmare to me. And I still do not understand why global anesthesia is not proposed to us patients, or why doctors who know how to proceed without pain don't train the others. Now, it's been 13 years that I've benefited from this marvelous lungs transplant. And my life today is not the one I expected when I was nearly 40. I'm still married. I'm still mother of 3, but a bit older. And I'm not working anymore. But I decided to take this granted second life as a bonus. Life is too short to look back in the mirror. I have to enjoy every bit of it and to make the most of it. I'm an active participant in my medical monitoring. I try to understand and follow the delicate balance of all the drugs that I take, the side effects also, how to cope with them. My prescription only contains 2 anti-rejection meds, 2 milligrams of cortisone, 1 antibiotic every 2 days, and some magnesium. Every 4 or 5 months, I have a medical checkup with my pneumologist in ERN-Lung hospital, a blood test and RFE, respiratory functional exploration, and a scan per year. And every year, I scrupulously consult a nephrologist, a dermatologist, a gynecologist, etc. But most of my time, I'm not thinking about my transplant. I practice sports like yoga, Nordic walking, biking. Wednesday, I'll go skiing for 4 days with a group of friends. Do gardening. I'm having courses at the Sorbonne in Paris. I give school support classes. I'm invested in the management of my co-ownership residence and also in our PHA National Association, HTAP France. And I have plenty of time for my family and friends. This morning, I had my quarterly checkup. My blood is good. My breath is very good. And my pulmonologist wished me a good ski weekend. Now, I never forget my donor, of course. Sorry. For this, it's always very sensitive.
No problem.
For this, my donor, for this incredible timing and extraordinary lungs granted. And I also know how lucky I am in this extreme health situation to live in France with some of the best specialists. Thank you very much.
Thank you so much, Florence, for sharing that with us. And I think it's more than understandable and very, very human that you are touched, and we all are touched by the graciousness of your donor. I mean, without him or her, you would not be.
Oh, that's great. Yeah, indeed.
And certainly, and for me as a German, today it's a very special day. Today in Germany, the Organ Transplant Registry starts its activity. It's a voluntary registry, and people who want to be registered for as donors can voluntarily register themselves. And that's next step, better to say, to improve on the lung transplantation rate. Florence, once again, thank you so much for sharing your experience. Thanks to Conrad and Laurent. We do have already a couple of questions from the from the audience, and I'd like to remind everybody that you can use your chat function in the channel you're using, be it Instagram or YouTube or, of course, LinkedIn, and ask questions. And we have a question here from Luis Baumann. Why does a difference exist within Europe about the use of LAS scores? We all live in the EU, so why not the same rules? And I think that's probably to use Laurent.
It's a difficult question. I don't know why. There is very different healthcare systems all across Europe, and there is very different level of development of the lung transplantation program. So I don't know why, but there were some collaboration between the different countries. So, as I say, some patients use the lung allocation score. It's a Euro transplant program, and other countries like France and UK, we have no lung allocation score. But finally, I think that we have similar results in the access to lung transplantations and post-transplant survival in each of these countries. The very big difference is for some countries, particularly in east of Europe, when we have development of lung transplantation program, and in this country it's difficult for the moment for PH patients to access to lung transplantations, but there were some collaborations to help these patients to reach lung transplantations between Austria, I think, like for example, and some east country of Europe. But I think that the future will be to develop a very strong collaboration between countries, but for the moment it's different rules according to each country. Yes.
Yeah, thank you very much. Yeah, we have a rather complex question to Konrad Hürzenegger from Elena Deboa. And it's basically, let me summarize probably, is there any genetic background that may determine the success of a lung transplantation or foster an antibody-mediated rejection?
A long question. Answer is short. I'm not aware of such a association.
Okay, thanks. Thanks for that very clear response. France, I wonder if you could summarize, or if you could probably say in a couple of sentences, what would be your advice to PAH patients who may be in need of a lung transplantation? We heard about too early, too late. I know this also from the CF field. I mean, it's sometimes a very difficult decision to take and to get on the list. What would be your advice?
You've heard that in my story, it was decided by the two doctors, two professors in Béclair. They decided it was the time, and it quite corresponds to what Konrad was explaining, and Laurent too. You don't have to be in such a bad shape that it will be very difficult afterward to recover from the lung transplant. So I don't know, it's a balance, and what is really needed when you go to lung transplant is to be, I know that it's part of the fast recovery that I experienced, is that you have quite a high level of mind. I mean, you have to be sure that it will work. You have to be sure that it's the solution. And if you don't believe in that, I mean, I really believe that it's more than 80% of the recovery. And I have a high level of investment, as I tried and tell it, in my recovery. I really wanted it. And this was, I suppose, understood by the professor D'Artevel, that audienced me, that listened to me, in order to know if I was able to go to transplant. And that was, I believe, it was noted down. You need to be convinced.
Laurent and Conrad, is that also your experience from a physician's point of view, that the patients who prepare themselves, who really want to do it, who are really committed, are doing better?
Yeah, maybe yes, because the motivation and the internal like feeling to participate after transplantation is so essential. When you wake up, as Florence said, you're basically bedridden. You can't move your muscle, and you need to kind of get out of bed and start training. And motivation is a very important part here. I just like to add a short comment, which Florence, your presentation was amazing, touching, and congratulations. What I found, I think, a very good take-home message here is that you were treated in a center of excellence. Like the names you mentioned that treated your disease, those are really well-known international experts.
Yeah.
And that's also the secret why, despite I think your overall situation, you made it out of hospital, and PH in general, and I think everyone here in this panel can underline this, is a disease that needs to be centralized. You need to have the patients move to the center rather than having small remote hospitals treating this disease. It's too complex. This is a strong plea for centralization.
Yeah, it's a very important point. I think that it's a lung transplantation for expert, and I think that it's very important to centralize this type of transplantations in very specific centers. To give the example of France, underline Florence, the transplantation for PH, 80% of transplantation for PH are performed in the same centers in Marie-Lannelongue Hospital, and I think that it's very important because it's very specific.
Yeah, and that's actually also the mission of the Alliance for Pulmonary Hypertension, which is, of course, hosting this webinar and this series of webinars to make sure that patients are aware and families are aware that there are centers of excellence. That's one point, and certainly also to avoid, just staying in a more peripheral place where the experience cannot be there. Short question to both of you, Laurent and Conrad: are you cooperating with patient organizations at your sites, at your centers?
So in our center, the transplant center is different than the PH center, but we are very close. Okay. And as I said during my presentation, we prepare the patient for this eventuality very early in the course of the disease, okay? And we have 3 times, as I say, we speak about this possibility for the patients very early in the course of the disease. And after we have the time of assessments, and we organize an assessments in the both centers, and after we decided the listing. And very early in the decisions, it's very important to involve, of course, the patients, but also the environment, the families, the friends, etc., to be sure that the patients will be ready for that with all the environment. It's very important.
Mm-hmm. Conrad?
If I
Yeah,
may,
same. Oh, sir, go ahead.
Oh, Florence?
to finish on France, complete what Laurent was just saying, we have our association, and it combines PH people and transplanted people.
Yes.
So it's quite a synergy also.
Conrad?
Yeah, no, I just wanted to add what I think is important is at the time, when you discuss transplantation, to kind of couple your transplant candidates with patients that already had undergone lung transplantation, because there are so many questions about, how will my life be, and very practical questions. Sometimes it's hard for non-transplanted physicians or surgeons to answer those questions. So that's important to couple those two patient groups, and for that reason we closely collaborate with transplant patient cohort support groups. Sorry.
Yeah, thank you very much, Florence, Conrad, and Laurent, for having joined us for this webinar tonight. This was the first one in this year, but the second one will follow soon on April the 29th. We will have a webinar on surgical intervention in CTEPH. Don't miss that one. April 29th will be announced already, also in LinkedIn and Instagram and other channels. Thank you very much for joining us this evening, and have a great day and rest of the day. Bye.
Thank you.
Bye-bye.